Okay, we'll wrap this up. And thanks a lot, guys. Hello, Abraham. Welcome. And we're going to continue on with Shugar Hinojosa, who did a fellowship with IPE in Nepal. And he's going to do a case presentation, correct, on cisternostomy. Welcome, Shugar.
Hi, John. John, before we start, I would like to ask Professor Wang, how many centers back in China that are doing cisternostomy? Because as I have seen, there's only in Nepal, in Biratnagar, this is the only center that I have seen that they're only doing cisternostomy and not the compressive craniectomy. Is it the same in your center? You are doing just cisternostomy, not the compressive, or you are kind of mixing up things there?
Did you get that question, Young Hung? Yeah, he asked, is at your center, do they do a lot of cisternostomies or decompressive hemicraniectomy, or how does that work? Let me unmute. Go ahead, Young Hung.
And now our center do cisternostomy at the same time do decompressing the craniectomy because it depends on neurosurgery doctor. So sometimes I do decompressing craniectomy at the cisternostomy. After decompressing craniectomy, I do cisternostomy. So at the beginning, so we should do this surgery safely.
Well, you know, are the centers of neurosurgery education teaching the juniors cisternostomy, or are they showing cisternostomy as an option, or is it pretty well you've really got to look for someone to train you in that?
Now I have some lecture to tell in my city, in my center, at my province. I have several conference meeting in China and present about cisternostomy. So many neurosurgery doctor began to do cisternostomy and learn about cisternostomy.
Okay.
Mm-hmm.
Very good. Okay, Shugar, you want to start your presentation, or you have more questions or comments, Shugar? You want to?
No, John. If you are up to, I can start right now.
Yeah, sure.
Yes.
You've screen shared before, right? There you go. You know how to do it.
Yes.
Yeah, and thanks for adjusting the time.
Okay. Yes, here is 2 a.m. in the morning, so
I know.
Sorry for the face.
I know. I'm in Miami, and it's 4 in the morning.
Okay. What I would like to talk about it is cisternostomy in low-income countries, like a challenge to develop in right now, especially for young neurosurgeons. I have been in Nepal for 4 months this year. So after that, it changed your mind to see all these procedures, because in the first moment when you hear about cisternostomy, it looked like too good to be true, and you have obviously some doubts about it and how to do it, because even if you study and if you see some stuff, you have to see it in life to understand a little bit. Okay, so we're going to talk about this quote that actually Professor Turian liked to always to talk about it. That is a quote for Machiavelli. It must be remembered that there is nothing more difficult to plan, more doubt of success, or no more dangerous than to manage the new system. So that's what's happening with cisternostomy right now. It's a new idea, and it takes a lot of time to understand it and to embrace it, okay? So this is my city. This is Cusco. This is Machu Picchu, one of the new 7 wonders of the world. It's a wonderful place to be. So low-income countries, actually, there are, like Professor Trian said, there is a lot of population in it. If you see the map and you exclude all the blue and light blue areas, there is a lot of population that are now living in these countries. Okay, we have almost all South America, all Africa, in parts of Europe and Asia. Now, TBI in present day, we have to understand that remains one of the most serious medical and socioeconomical problems in neurosurgery, and is a cause of mortality and long-term disability. So what we have right now to fight against TBI? Now we have to understand that there is almost 13.8 million cases per year that require neurosurgical care. And of them, almost half of them are TBI. Only 20% cerebrovascular, and the other ones, like you can see in this slide, there is just a few. Now, there is more than 69 million of people affected worldwide from these TBI problems. Okay, so what are the challenges of cisternostomy? The challenges of cisternostomy are especially 5. That we need to have school-based surgery knowledge. You have to develop microsurgery and knowledge. You need instruments as microscope, high-speed drills. You have to have some kind of open mind to embrace the new knowledge. And sometimes something that I have talked about with older people is that you have to have the support of your main chair. Because as new surgeon, as a new junior neurosurgeon, you have to have the support of your main chair. There is no other way. And in the end, all this is about a leap of faith. The school-based surgery knowledge. We have to understand that we need a proper training, and we have to know about the knowledge of unlocking. We have seen Professor Turing talk about unlocking of the brain many times. If we don't have this kind of concept in the right way, it is really difficult. Now, there is some neurosurgeons, older, that have developed a lot of skill that they don't need to do the unlocking. For young neurosurgeons, I think it's primordial that you understand this, because you earn like maybe 4 millimeters into the brain, that for a person that is not so skillful in that moment, because we don't have all these years of preparation, that can make a change. So it's really, really important to understand school-based surgery. Microsurgery knowledge. We have to be trained in laboratories, in proper set laboratories. We have to be comfort with the use of microscope. And of course, hands-on courses are the best. We have had the opportunity to be trained with Professor Trian, and it's actually a life experience that we have to do it. I mean, the skill that you develop using every day the microscope is different. So unfortunately for young neurosurgeons, the lack of use of microscope in brain trauma is something that we should now embrace it. We have to try to do it. Sometimes when maybe you are just closing the patient because the main surgeon already finished the job, you have to bring the microscope to start to develop your skills. Now, in low-income countries, the problem is that there is no proper laboratories set up here. For example, here in Peru, there is only one in the Child Institute. And even though these ones only make maybe 1 or 2 times per year a course, and usually there are only 10 or less spots to do it, and only takes like maybe 1 week. So 1 week of preparation with the microscope is not enough. We have to have this kind of instruments in our hands so we can develop the proper skills. Like I said before, the instrument, microscope, drills, and surgical instruments are really, really expensive. And in low-income countries, it's really difficult to gain this kind of stuff. Even if you want to, ask for the government to buy it, right now there is a lot of problems with to acquire this kind of equipment for the price and also for all the papers that they need, especially because, like we said before, microscopes usually they are not being used to neurotrauma, that is the most common and frequent pathologies in the hospitals. So it's really easy for a neurotrauma surgeon to say, I don't need a microscope because I don't do tumors, I don't do vascular surgery, I don't do aneurysms, so I don't need a microscope. But actually, if we embrace this, if we understand that the use of microscope has improved all the areas of neurosurgery until now, except brain trauma, because we don't want to use it, we will figure out the way to put it back into the field. We have here some pictures of Gratian working with the microscope every day. Every day we have to practice. Obviously, we don't have the opportunity in all the cities here in Peru, in low-income countries, to have a Pentair 900s or a Kinevo or the new ones of Leica. But even with a not so superior microscope, we can do cisternostomy. Obviously, for example, the Trinian 3D is a really, really good tool so we can understand better the procedure itself, being in the OT and be part of the surgery. Now, it's really, really funny to see, for example, next month in Barrow Institute, they equipped with 11 new size Kinevo 900 microscope. These ones are as many as maybe there are in Latin America, because I know that in Mexico they have one or two, in Panama they have one, now in Peru we have one. So it's really, really impressive that only one institute can buy 11. So that is because they manage a lot of patients, and they also, the person that work there, they try to embrace it, they try to put together some money with all these fundings and everything. So there is always a way if there is a will to do it. Now, a system of knowledge. Sometimes I can be really, really assured that, especially for young neurosurgeons, when we talk about cisternostomy with the older brothers, they sometimes are skeptical about the procedure. That's because they don't understand properly cisternostomy. There are a lot of times I have been told to say, if you want to do cisternostomy, why don't you just put a ventricular drain? They don't understand. They don't know about chief edema. They don't know about cooling and cleaning of the brain. They don't know about the lymphatic system. So it's really, really important, like Professor Trian pointed before, to understand, to study, to realize how this cisternostomy works. And don't just say that it's not a good procedure because you don't hear about it or you don't know about how it works, okay? So it's really, really important. No, there's a lot of papers right now published and are free in the internet when we can navigate a little bit more about the concept of cisternostomy, the surgical technique also, this about chief edema and everything. So it's really, really important to embrace the new knowledge. Support of the main care is one of the most important things also because, like we heard before in the history of how cisternostomy was developed, that in the first moment even Professor Chen have some problems with the other surgeons. But the main chair says, okay, is the same flap for a micronectomy. You are opening the cisterns, it's nothing new, so you can do it. Because otherwise, it's really, really difficult, especially when the people are really, really, have a really, really narrow mind, so they can want to change things. Sometimes, just because the compression maybe is easier to do it, it takes less time, it takes less effort, it takes less skills. But either way, it's really, really important to talk with always and have support of the older brothers. In the end, it's a leap of faith. I remember when I was in Naples, when the first time that I heard and saw about cisternostomy. So there's a lot of questions, especially when you have a really, really tight brain. So how can you go into the cistern? Because sometimes in aneurysms and tumor, we have fought with the brain, with a really, really tight brain. It's really, really difficult. So that's the trick. I mean, you don't need to open all the dura, only do a little small cut into. So through there, you go to the cisterns. So that's why I say that it's really, really important to be trained and to learn this kind of procedure with someone who actually knows the procedures. Here we have a map of all these surgical care we need in low-income countries. And if you see the percentage of people that they are needing, it's really, really alarming. There is almost globally 20.6 million of cases that need surgical consultants. In low-income countries, there are 70.6 million. In high-income countries, only 4.3 million. Neurosurgeons worldwide are almost 50,000, of which almost the half are in high-income countries. Okay, in Western Pacific region, in China and Japan, they have almost 18,000 neurosurgeons. In Europe, 10,079. Canada, almost 5. In Africa, we can see there's 940 million people, and there's only 488 neurosurgeons. So it's a lot of work for these neurosurgeons to take care. In India, of almost 1.3 billion people, there's 3,500 neurosurgeons. Okay, it says this last report that Africa needs to increase neurosurgeons in almost 1,700%. There's a lot. And in low-income countries, we need more than 20,000 neurosurgeons to decrease this breach. Now, the problem is that right now we are seeing an increase of neurosurgeons, but how many of them are well trained? I mean, in Bogota, about a couple of years ago, they said there is training capable and competent neurosurgeons is a fundamental step in establishing equal access to safe and timely neurosurgical care. But how can we do this if even with a micronectomy, we don't have the same clear? We are fighting of a procedure that has almost hundreds of years. They don't know a clear visualization of how to do it. So with this new cisternostomy, how to do it? So now that things have changed, we have internet, we have this kind of windows so we can learn from each other. And it's time to do it. It's time to maybe leave apart a little bit of our ego and share of knowledge. Young people have new tools and they have to share it. And all people have the experience, the enough experience, so we can be more effective. Okay? The lack of neurosurgical attention, it says it causes 3 times more deaths than AIDS, TB, and malaria together. According with the World Bank, only 11.8% of surgeries are covered in Africa, and there is a need of almost 1.3 million more procedures that nobody is doing. So where are we now in Peru? There's only 130 neurosurgeons, approx 433 million people. And of these 130 neurosurgeons, almost 80% are in the capital. So in the province, there is no lack. This one is the division of the Antonio Lorena Hospital here in Cusco. It was an old hospital, and they say that they're gonna build a new one. It's supposed to be like the vision of we have in the left side of the screen, but actually we have now the lower part. This is our hospital now, because for problem with corruption, they spend the budget of this hospital for the hospital and they leave this. So now we are struggling about with the building of the new hospital. We are improvising procedures. We are not doing the work properly, okay? This one is in the left is the original hospital here in Cusco also. It's a public hospital. And there's only 3 neurosurgeons right now in there. I've been told that the past year, the government offers to buy a microscope and the neurosurgeon just says no. So how can be this possible? I mean, they don't need a microscope. So there is only that this kind of narrow minds that making things worse. Okay, now in the right side of the screen, we have this semi-private hospital here in Cusco. They have a microscope, a size microscope. They have all the implementation, but they are not doing this kind of procedures because they don't know about it. They don't want to improve. They don't believe in the procedure. So the problem, like I said before, they don't know about it. They don't know nothing about the lymphatic way. They don't know about shift edema. They don't want to learn. So it's really, really difficult to change this kind of stuff. Now, remember that the compressive craniectomy is not something that only Cocker discovered like 100 years ago. My ancestors, the Paracas, they already do it like 500 years ago. And it's a procedure that, okay, it can be useful in the last tier of the treatment, but otherwise it's not a good procedure. Do not forget that in TBI, ischemic changes have already occurred, associated primary diffuse axonal injury. Axonal stretch caused by shifting brain bulk. So just take it out the bone is nothing new, is not gonna fix the problem. Cisternostomy have a more physiological approach to this, and we believe in this. So finally, motivation is what gets you start. When you see cisternostomy, you see and you believe that can works, you go for it and you learn it. But the commitment is what keeps you going. And I think one thing that we are lacking now with all the neurosurgeons is the commitment to save lives, the commitment of give the best of us to improve the life of this patient that goes into our hands. Finally, just thanks all the people, Professor Tri and all the guys that I have met from my trip in Nepal, and regain the commitment of develop this in my country and hopefully in all Latin America. Okay, thank you very much.
Thank you very much, Shugar. Thank you for staying up so late to give that presentation and to associate with our Chinese neurosurgery brotherhood. I have a question. I'm not a neurosurgeon. Were you acquainted with cisternostomy before you went to Nepal to train with IPE?
Actually, I was in Nepal when I heard about cisternostomy. It was between two conferences of the compressive craniectomy because back then I thought that it was the only thing that we can do back in that moment, like a year ago. But the disposal of Professor Trian to embrace me, to teach me, it was amazing because I have doubts, of course, as any surgeon. Mm-hmm. And he told me something like, okay, there is a lot of things that you need to understand. So why don't you came to Nepal? And I said, okay. And a couple of months later, I was there practicing, and it was like a life-changing experience because it's really, really something that you have to see it. I have Eugenio Cerezo, that he was this neurosurgeon from Venezuela, that he was there. And he told me something like that. It's something like, you have to see it to believe it. And I have seen people going really, really in bad shape into the OT. And after a week, going out from the hospital walking. And that feeling that you are doing things right, that you are saving somebody's life, is something that I think we should never forget.
Mm-hmm. Okay. How about you, Gleb? Did you hear about cisternostomy before you came to see IPE? You did your short
fellowship.
You never heard of it before you went?
No, I heard right before scheduling the fellowship with Professor Chiran. Mm-hmm. First of all, I would like to say hello to Jamil. Hello, comrade. It was a nice lecture, a really nice one. And I would like also to add some of my thoughts because a few days before this big day, yes, we were talking with Jamil and sharing our thoughts about the problems of cisternostomy in the third world countries and so on. But right now I'm not at home and I have a lot of internet problems, and so it was kind of not that easy to talk and to describe all our thoughts, but I also like to add a few concepts. You know, for example, in Russia, the situation in different hospitals in different cities varies a lot. And what facilities do we have, for example, in specialized neurosurgical institutes is not the same as what do we have in peripheral hospitals. And I heard from my colleagues that, you know, some of them were sent to really, really small local hospitals in my home region, in the Rostov region, and they were forced to perform at least some kind of surgery for brain trauma in really, really strange situations. Like they had only lancets, hangers, and some kind of gas stove burner, you know, so no, and a pincet, so no monopolar, no bipolar, nothing, no microscope for sure, yeah, you know. So for some cases, the neurosurgeon as a physician, you know, he should think about what he can do in the facilities that he have. But on the other hand, he should also work trying to improve the facilities to be able to deliver the best treatment options for each concrete patient. So I first heard about cisternostomy last October, so almost a year ago, when I was watching the skull-base conference in Tyumen in Russia. Cherin was there delivering his concepts of skull-base surgery and also a cisternostomy concept, and I felt a bit great about it because, you know, for the first time when you're a neurosurgeon and you hear about it, you think that, come on, it can't work. Yeah, it's just complete crazy stuff. This guy, he's insane. I think that's the common idea of maybe like more than 90% of neurosurgeons. But as time goes by and I keep thinking about it, keep analyzing it, start reading some papers about it, and a few weeks later, I decided that I should contact with him, and if it's possible, I should go there and see it with my own eyes to get sure that that's not work be true. Yeah, but when I came in February 2019, I was completely surprised about the professor itself. Yes. About their facilities in Biratnagar. That's an amazing neurosurgical department, and also about all the skull-based concepts that are supported by Professor Cherin, and moreover about the cisternostomy itself. So I think that getting known with the cisternostomy and keeping analyzing it and improving our neurosurgical both skills and facilities will lead our countries, our world to finding a right place to cisternostomy, and will give us an opportunity to do it. Yes, to perform this kind of really complex surgery to save someone's lives.
You know, as far as the cost, what is the cost of cisternostomy compared to a hemicraniectomy about the same, or is it one is less than the other? Is the cisternostomy a relatively inexpensive procedure, or is it the same as other procedures for head trauma?
I think that the main problem is
the instruments in your hospital. It shouldn't be more expensive.
Okay.
Even so, if the works of Professor Wong, they have showed that the time in the ICU, the time in a ventilator is less. So it should be cheaper for the hospital, cheaper for the government. And also the outcome of the patient, that which is better, it should be cheaper to keep these kind of patients. I mean, without any kind of distress or any kind of sequels. Okay, so actually it's cheaper, I guess. I don't know, Gleb or Professor Wang, if you can.
Yeah, I think that the patients that recover well after cisternostomy don't need that complex rehabilitation. That also saves a lot of money, yes, because rehabilitation after severe traumatic brain injury, you know, it's like a really long story that takes months. Yes.
Yeah, you mentioned the microscope, and we talked a little bit about this before. Of course, that's a hindrance to hospitals, the cost of a microscope. And Ike was talking about investigating getting cheaper microscopes for developing countries. So I guess that must be a big hindrance, right, for hospitals to get them. The microscope is a cost. It's pretty expensive to get that microscope.
Microscopes are pretty costly. Yeah, that's true. So, you know, it depends on what kind of microscope are we talking about, but, you know, it's kind of at least a few thousand of dollars. So, like, that's not
the
the
one we
kind
saw
of
at Barrows. Which one was that? The 9 microscope from Barrows. They're
11
11
size canals, right?
Yes, yes.
Each of them costs more than $1 million.
Well, each one.
Each one.
Each
Yeah.
one. Wow.
But looks like they are just the kind of also kind of institution that are, you know, kind of, I don't know, testing this microscope. So
Oh,
maybe
okay,
some
for
of
the
them
company.
are, you know, yeah. Maybe some of them were just send them for free, yes,
Right.
for operation or something like that. But still, yeah, I would like to have the same one in my hospital.
Well, that brings up a point. Do medical device companies help pay with the cost of a microscope to third world countries? Do they get involved in that at all, or that's not done? Like with Storts getting, you know.
Our federation gives some help to some countries. If you send it your application, they evaluate and they can send you some really, really basic microscope and drills.
Okay.
But even so, the question is, like, in countries, in really, really high income countries like Japan, like US, what do they do with the old microscope? Because I would be more than glad to get one used.
Right.
As long as it's just functioning. So I think the problem is that we have to, there is this declaration of Bogota, and there is also some works about, with Professor even Justin and everything. We need to work together. We are only 50,000 in the world. So it's not like we are a lot, we are just a few. But if we work together, maybe something that you are not using, I can use it.
Mm-hmm.
And the problem is that this should be the role of World Federation to try to interconnect all the people so we can work together, even to training. Because obviously my condition here is completely different from a guy from Switzerland or from Germany or from US. I cannot travel a lot. Mm-hmm. So there's this guy, Manuel, for example. They do a lot of research, and he tried to always to get some scholarships, and they help them. Mm-hmm. But it should be something more specific, maybe to help other residents and young neurosurgeons so they can be more skillful and they can help. Maybe.
And they're very necessary. You know, I'm not a neurosurgeon again, but just from listening to you guys, it seems that it's almost necessary for trauma. So do hospitals, I wonder if they look at it like that, or they look at it like, well, it's a luxury item, we really don't need it. Is that the attitude of some hospitals? It's really not necessary. You can do, you know, they've been doing brain trauma for years without it. Is that the attitude you get with the hospitals? So
I think that's not only about for trauma. Some neurosurgical departments, you know, they don't have even a microscope for all the neurosurgery. So, for example, in my country, in some departments in peripheral hospitals, they are forced to do neurosurgical procedure under loops, you know, and come on, that's not the right facilities for the neurosurgery in the 21st century. But still, it happens. On the other hand, we also have maybe not the same well as equipped as a Barrow Neurosurgical Institute centers, but you know, for example, they have a very nice facilities in Tumen, and they have like their own micro lab with 10 microscopes, each with a TV, yes, to let the others control what's going on under the scope, and a lot of structures, micro instruments, and so on. So you know, I think that everywhere in the world is kind of the same. Yes, for example, somewhere in the capitals and the big cities, in rich centers, you know, they have almost everything. On the other hand, in a lot of hospitals, you know, people, they need to do kind of create surgeries with I don't know, sticks and stones, something like that.
You know, well, anyways, I'd like to thank all you guys for coming out, and Shugar, thanks for staying up. And we're going to end it right now because we couldn't get a hold of the speakers, to Dr. Daniels, and perhaps we'll do that at another time. But I'd especially like to thank all the Chinese neurosurgeons for coming out, and thank you, Young Hong, for arranging for all your associates to come. So we're going to end this now formally, but you guys can hang around and we'll just chat, okay? So thank you.